So Sorafenib has gone through a randomized phase 3 study against placebo in patients with RAI-Refractory thyroid cancer. This was the decision study done by Dr. Marsha Brose. It was an international study, and it was the first study that was completed that did show an improvement in progression-free survival. There is a crossover as part of the study. There is no benefit in overall survival, but no one's sure if there's no benefit of overall survival because of the crossover. The one thing about this study that really has, it always makes us a little bit concerned is that the response rate was not that high. It was only around 12 to 13%. The progression-free survival benefit compared to placebo was only around 5 months. So we didn't see this gigantic benefit by using Sorafenib in this setting, but we did see some benefit. The other thing to always consider is toxicity. At the dose that is used for Sorafenib, which is 400 milligrams twice a day, about 65 to 70% of people needed a dose reduction. So it's very common with a drug like Sorafenib that patients can't stay at that top dose because of side effects. So hypertension is very common with this whole class of medications or VEGF TKIs like Sorafenib. Sorafenib definitely does not cause as much hypertension as some of the other drugs, but it's still a concern. What we typically do is, at least at Memorial, is we have patients check their blood pressure on a daily basis for at least the first 4 to 6 weeks that they're on treatment. We give them a criteria, which is, for me, 140/90, that I want them to call us about the blood pressure going up. We don't always make adjustments with blood pressure medications just for that, but if we want to know if that's going on, we sometimes will always have them recheck it about half an hour to an hour later. But over the telephone, we'll start making adjustments with blood pressure medications very early. If you try to catch up, it's near impossible. So you really want to make these adjustments really quickly, and you get a person on a good blood pressure regimen that ends up working for them. And it's not unusual that a patient may need 2 or 3 blood pressure medications, but it's not something you really could ignore, and you really have to watch this carefully. The GI side effects are not as much of a big deal. People might have some diarrhea from it. It's not so common that it's very worrisome, but it does happen. If it does, you make sure patients know to take Imodium. You don't want patients getting dehydrated. There are sometimes where people will feel like a little almost gassy, and using simethicone can help for these patients as well. The bigger problem is actually hand-foot syndrome, and that's probably the highest reason why people go down on the dose of Sorafenib, and it's important to prophylax patients with Sorafenib. About 60% of patients are going to get hand-foot syndrome. And if they use creams ahead of time, if they know what to avoid, so things you want to avoid are things that maybe where you have to really grip something. The worst hand-foot syndrome I've seen was in one person who was a tennis player and another person who actually was a carpenter and swung a hammer. And the person at least who swung the hammer, I gave the advance notice they're going to run into trouble, and they did run into trouble. Same thing with the tennis player. She went out to play tennis, and by the time she was done, her hand was completely swollen, completely red, and it bothered him quite a bit for a while. The good thing is that it's easy to take care of. You can hold the drug. It usually goes away after, for a few days to up to a week. And then if it's something you really need to do, which often you have, just go to a lower dose. And you actually find the lower dose patients can tolerate it very well. But it is important to make sure that they're using creams and making sure it's important to use appropriate footwear. I often tell people use like Dr. Scholl's gel insert. Using flip-flops is not probably the best thing in the world. Walking around barefoot is always probably not the best thing in the world. Try to have like some type of cushion.
When I'm using Sorafenib, a lot of people ask me, where do I start, what dose do I use, and what doses do I change? And I will say that I do have a lot of experience with this drug because I did the phase 2 as well as many patients on the phase 3. And I will say that my experience says, and also as a purist, if you have a decision study that you use dosing in a certain way, if you want to get the same results as the study, you really need to dose it in the same way. So if you start doing things, instead of starting at the 800 milligrams a day, which is what is used in the decision study, and it's obviously what's on the label for prescribing information. If you start to play with that with lower doses, I don't think you're going to get as good a response. That said, you do have to adjust doses occasionally for side effects. So in our practice, we start everybody at 800 milligrams, no matter what. And then if they come up with issues with hand-foot syndrome or whatever, if needed, we do go down in dose. I do everything in my power to keep them either at full dose or 3/4 dose, because in my experience, anybody who goes below that, I don't think they get as good a result. We had a couple of times where, for various reasons, patients did go down to half dose, and initially what happened is their tumors started to grow again, and we had to come back up to 3/4 dose. I also think it's important for the community physician who may not give it a lot to not be overly ambitious with, or sort of lenient with dropping the dose. It's very important that you take managing the doses much more seriously, because if you do decrease the dose, I'm very confident that you won't get as superior a result. So there's a balance there to be met where you want to maintain some benefits for the patients, as far as you don't want them to have a terrible quality of life. So you have to take intervening in these issues very, very strongly with over-the-counter medications or even non-over-the-counter interventions, and really interact with them about their side effects and try to control them first and foremost as much as possible without decreasing the dose. Because if you do that, the patient will have a better outcome, they'll have better shrinkage, and I think that in the long run they'll last longer on the medication than if that's the first knee-jerk reaction. And I really do think that it takes a physician who's very committed to the patient, because you have to really listen to them. You have to really ask them about the side effects. But if you want to be successful, managing the side effects is actually absolutely paramount to getting a good result. And dose intensity should be maintained as much as possible. The optimal duration for treating patients with sorafenib is as long as they have clinical benefit. So when patients have their initial treatment, they often shrink some, maybe not a lot, but they'll usually have some shrinkage. And then they'll sort of, after about 6 months, 4 to 6 months, they'll sort of get into a phase where it doesn't shrink anymore, but it doesn't grow. And then the point to do is to try to maintain that as long as possible, as I would argue to be very good about managing side effects and try to maintain that dose as long as you can. The optimal period is as long as there's clinical benefit. In the decision study, we made the choice that at the time of progression, if that progression was, say, a solitary nodule that could be treated by either surgery or external beam radiation or cryoablation, some local therapy, that patients were then unrandomized. That were, first of all, assuming that they've been they're on the therapeutic arm. If they had that solitary progression, they had the choice of getting that treated and then continuing on the drug. And we found that actually, say they got a 10-month period on average or 11-month period prior to that event, if that got treated, they often got almost a similar duration of benefit after that. So I would argue that as long as most of the nodules are responding, you would like to keep them on the systemic therapy as long as possible, treat a solitary local recurrence as needed along the way. And in that way, we're finding that clinical benefit far exceeds the actual progression-free survival interval, because sometimes we can manage these solitary nodules and then have them continue on and get another 10 months or 11 months of benefit.